Next, I call upon Dr. Anil. He is the head of cornea services at Amrita Eye Institute, Ernakulam, Kochi. He will be talking on surface ablation techniques.
Yeah. Thank you, Kala, for the opportunity. So PRK seems quite an outdated procedure now, but with the eminence of this lenticule-based procedures like silk and smile, but still it has its relevance. If you look at some of the major institutes like for LV Prasad, almost 65 to 70% of the refractive surgery what they do is PRK. Mostly other part it's mainly femto or femto or smile. So we all owe the XMR based refractive surgery. We all owe to this person who had this thought process and had it done as early as 1985. The major advantage with surface ablation is that absolutely there is no flap. So all these disastrous complications we don't get to see. So which are the patients we do surface ablation for? One is this low or borderline pachymetry. Sometimes you see patients in whom, like you see a borderline pachymetry, then you give them for an ICL workup, and we found that the anterior chamber depth or some other parameter is not really matching. In such a patient, you can revisit and you can think of doing a PRK in such a patient. If it's a very flat K or a very steep K, LASIK, this regular microkeratome LASIK is not a great option. With femtosecond LASIK, it is possible. If you have a history of epithelial basement membrane dystrophy or recurrent erosion syndrome, then LASIK is a big no-no. And in PRK, actually, PRK or PTK is actually the treatment for recurrent erosion syndrome. So if you have a tendency, sometimes you see that some patients, when you take a flap, you see that the epithelium is, half of it has come off. In such patients, they are prone for recurrent erosion. Their adhesion complexes are not great. And such patients, I think it is PRK, this is the preferred procedure in such a patient. And if you have a very narrow orbit in which you cannot keep the suction ring, or if you are involved in contact sports, it may not be a great idea. Then if you have an irregular cornea, especially post-keratoplasty, post-RK, or post-LASIK residual refractive errors, PRK appears a much better option, especially the topo-guided PRK. So we know that the biomechanical strength of the cornea goes down in every procedure, and if you make a flap of about 90 to 100 microns, there is a loss of corneal strength of about 14%. And if you make a 140 or a 160 micron flap, there is a loss of corneal strength of 30%. So with PRK, the loss of strength is much lesser. So I'm also not a great fan of PRK unless the patient is otherwise unfit for LASIK. I don't prefer PRK. But this was I think, collection of cases, 36 cases in whom this was in the previous institute, in which regular LASIK could not be done. And I think as you see in the results, most of them were high myopes. The mean pre-op spherical equivalent was minus 9.35, and it came down to post-op was only 0.23, which means he or she can be essentially off glasses in most of the cases. The major problem with the PRK is the pain and the slow recovery, the reason why people shun away from surface ablation. And in the long term, PRK haze is the thing that is important. So I'm not going to the details, but I think I would say there is a normal response that we see. So when there is some cut in the epithelium, whether it's a PRK or a LASIK, there is some keratinocyte activation, there is some inflammation happening, and there is a normal response, and we are expected to, the response will come down within 6 to 24 days. But if it goes to the next level, then only this haze will happen. So the keratinocyte activation and inflammatory mediators will bring in myofibroblast and fibroblasts, and with that will cause the haze. That is the problem with PRK. So that is why initial period in the 90s, I think PRK was quite popular. I mean, early 90s it was popular. By early 2000s, I think the popularity came down because the mitomycin was not available. The resurgence of PRK happened after use of mitomycin, and we all know that 0.02% is the one that we usually use. It's I think we have to be careful in that Asians have definitely a higher incidence of stromal haze. Just like we get more keloid, we can get more haze also after excimer laser, and that has to be taken into consideration. So, as a routine, we keep about the mitomycin application is for about 10 seconds for every diopter or 1 second for every micron. So I think I'll just touch upon the preferred practice patterns of PRK surgery, which came in AJO 2020. So in the preoperative, we have to, especially in Asians, we have to give some importance to the blepharitis, because if there are inflammatory mediators already in the conjunctival cul-de-sac, the chance of haze would be more. So if you have MGD or dry eye, treat it very well and then only take up the patient. So if you have MGD especially, I think it's a wiser idea to give steroids preoperatively. I think for 4 weeks you can really bring down the inflammatory mediators in the cornea. Then if you have if you have eye rubbing, acne and all that also, everything has to be taken care of. In the interest of time, I won't be going into the other details. See, some of the systems, I think, produce more haze. For example, Radhakrishnan and Summit technology had more late haze. We don't know exactly what is the reason for that. 1 minute more, no? So, in LASIK, there is, I think I won't go into this. Basically, intraoperatively, mitomycin is the one that you have to use. So we can actually use contact lenses, and the contact lenses can be impregnated with ketorolac, and that will reduce the post-op pain. I don't as a routine use it. Quite often I use this patches which are available nowadays for the intense pain that you have for the first 24 hours. We have buprenorphine patches which are approximately 1,000 rupees. That is quite useful. I think the plastic surgery people and all quite often use it. Only thing is, in a small percentage it causes nausea, but otherwise they are well accepted. Post-operative pain is the thing that you have to be careful about. You have to give tramadol and paracetamol. Ensure that the follow-up is very good. And topical steroids have to be given for 8 to 12 weeks. And you have to make sure that you avoid sun exposure for about 6 months. So once you get a late haze is the thing that we are all worried about. I think the treatment is much more difficult. You have to give a topical steroids for about 2 months. You can try doxycycline, vitamin C, UV protection, and lubricants obviously for 6 months. Tacrolimus is something that I use for haze, when especially people with blepharitis, I use tacrolimus in the long term. So I would like to conclude saying that PRK is a procedure still going to stay here. I think two big procedures have stood the test of time. One is the PRK and the surface ablation, and second is the lenticule-based extraction. And it's important, slightly more important, to pay more attention to the surface and the inflammatory conditions in the cornea and the post-operative care if you are doing PRK. Thank you so much.
Thank you, Anil, for that nice paper. As Anil pointed out, the main problem is the pain and the haze. If that is pain and haze is not there, so many more people would have adopted for this particular procedure.